Thank you very much for the invitation. It's a great honor. I'm speaking from the Ticino to you today, and I will tell you what I found about this topic. So I will start to share the screen. I hope you hear everything well. Let me, I will not introduce this in very much length. You all know about the principle of this nanoparticle formulated mRNA, which is not self-replicating, which after injection is taken up, is protected by the lipid nanoparticle from degradation, is then delivered into
Ali, we don't hear you.
You are muted now. You have to unmute.
So do you hear me? Is it okay?
Yes, now it's okay again.
Good. So the mRNA is delivered into the cytoplasm where it is transcribed. In the case of the two mRNA vaccines for COVID-19, they contain a stabilized mRNA, which encodes a altered spike protein from the early sequences of the Wuhan isolate that has two amino acid modifications such as to render it a spontaneously aggregating to a trimer, which then has a quite stable configuration on the cell surface. Let me go to the next slide. This is the composition of the mRNA vaccine of Moderna. I show you most of the data from the Moderna data, but the Pfizer-BioNTech data is very similar. So also the clinical data that I will show is quite similar. So I don't have any preference for either of those vaccines. So here is the composition, the chemical composition. You have the mRNA that encodes for the pre-fusion stabilized spike glycoprotein. Both vaccines have practically identical mRNA sequences. Then you have the lipid nanoparticle composition, which is a little bit different between the two products, which contains different types of lipids, such as to render the particles stable and fusogenic. You are aware that the stability of the nanoparticles differs a little bit, such as the Pfizer BioNTech nanoparticles, they need to be stored at lower temperatures. There's also a little difference in the mRNA content in that the Pfizer BioNTech contains 30 micrograms, whereas the Moderna contains 100 micrograms. And then there are, what is important to underline is the PEG, polyethylene glycol, that is contained in both vaccines. They are intermediate molecular weight of 2000 in both vaccines. Then you have other stabilizers that are required for the stability of the product. Let me first show you the clinical studies. Again, I took the Moderna data. I show you those both to illustrate the development process and also to give you an idea about the safety population that is available for those vaccines. The clinical study program from Moderna, also the one for Pfizer-BioNTech, was novel in that the phases 1, 2, and 3 were basically running in part in parallel, and knowledge gained from one study was used to further develop the other studies. And this was not done in a sequential way, but in a parallel way. This permitted the acceleration of the development. Let's look at the phase 1 study that was done with the Moderna vaccine. This was a dose-ranging study to look at the safety and immunogenicity in healthy adults above 18 years. There were 3 age cohorts. 60 persons were 18 to 55 years old, then a 56 to 17-year-old 30 people cohort, and above 70 years, again, 30 persons that were given the vaccine. There were 4 dose levels from 25 to 250. They looked at immunogenicity and also at safety. I just pick out some interesting data. Here you see the antibody titers that were reached, given as geometric mean titers. And you see the orange bar, which is the level that you would obtain with convalescent sera. And you see that after the first dose, after 15 days, there was not much of an antibody response. It took some more time, and it was really after the second dose that the antibodies were going up. The antibody titers were very high. They were surprisingly very, very high. And you see also that they maintain higher than convalescent serum levels in younger individuals up unto 120 days. And you also see that the over 71-year-old, they tend to lose the antibody titers a little bit more rapidly. Based on these data, the phase 2 was done. It was still done with 2 dose levels, 50 micrograms and 100 micrograms. There were larger numbers, 300 people were 18 to 54 years old, and over 55-year-old, there were again 300. The comparison showed that actually both doses induced comparable binding and neutralizing antibody levels. The safety was not problematic, and there were no problems other than local and systemic reactions, which I will show you afterwards. Then here you see some data about the time points again, using the 100 microgram dose, and you see that on day 29 there is some antibodies, but they really start to go up after the second dose. The phase 3 study, which will give us most of the data about safety, was done in such a way that there were 30,000 adults more than 18 years of age, randomized 1-to-1. Again, this is quite similar to the Pfizer-BioNTech, only that the Pfizer-BioNTech study was done in other countries. It was done in Brazil, South Africa, whereas this study was done mostly in the US. The Pfizer study included somewhat more people. There were about 40,000 people, so 20,000 that were randomized. The dose chosen was 100 microgram, and they tried to include quite a lot of patients with risk factors. You see, there was a goal of including up to half of the total population with risk factors, or people above 65 years old. It was quite similar in the Pfizer vaccine, although they included a little less patients with risk factors. The follow-up for the safety was active, solicited in the first 7 days, and after the 28 days, they were the follow-up was done a little less intensive for adverse events. But as you will see in the flow chart that I will show, there was a good level of care to detect side effects of the vaccine. The planned study duration is 2 years. As you all know, we are not there yet. We have data basically of up to 2 months after the second dose. The endpoints are quite standard. It was a typical vaccine efficacy endpoint. I will not go into details about that, but show you the schedule of the study. So they did safety calls after the first vaccine, and they did also nasopharyngeal swabs to detect carriers at the beginning at the moment of the second vaccine, and there was quite a careful follow-up of the patients with regular safety calls. Up now we have only the 2 months data, but the study really plans to look at safety also beyond these 2 months up until 2 years. And that's the kind of Kaplan-Meier curve of the infection rates in the placebo and in the mRNA vaccine groups. The data, as shown in the vaccine efficacy, which was also highly publicized, is given here. You see that the 30,000 vaccinees, they had 5 clinically and then microbiologically or virologically confirmed cases of COVID-19 disease. So these not carriers, but diseases. And you have 90 in the placebo group. If you split it down to the age strata, you see that also the 65 and older have a similar vaccine efficacy. Although you see that the numbers here are 0 versus 15, so it's a little bit less robust. There is also protection against severe cases of COVID-19 disease, which is comforting, important. We will talk about it, about the phenomenon of antibody-dependent enhancement of viral infections. So there was no indication that such things would occur. But again, these are not huge numbers. Let's look at the safety, which is basically the main subject of my talk. Here is the data set or the population that was the object of the assessment of safety of the Moderna vaccine. Again, there's a similar safety set in the Pfizer-BioNTech application. So you see these are consistent numbers. You also see that the retention of subject in the study was really good. There is no real problem there. Let's look at the local reactions, and they are shown here, again, separated by age strata. On the left is 18 to 64, and on the right, the over 65. And you see that the local reactions are clearly much more frequent, 4 times more frequent with respect to placebo. Grade 3 reactions were present, not really super uncommon, but they were not very frequent. Pain was very, very frequent. You see there's a significant difference between pain occurrence in the younger versus the older subjects. This is a common theme based for almost all of the reactogenicity being the local or systemic one. You see also erythema was quite infrequent, whereas swelling and also axillary tenderness after the vaccination was really quite frequent, clearly more frequent than what you would expect or what you see in a influenza vaccine. The data that I just showed you were after the first dose. Here are the data after the second dose, and you see that all these numbers go up a little bit. So the first shot is, I would say, like a bee sting, and the second shot is like a wasp sting. Certainly not like a mosquito sting, which would be what you have after influenza vaccine. There are also more systemic reactions that you would expect from an influenza vaccine. For instance, you see that in the systemic reactions, they were 4 out of 5 people had those. There were quite a lot of grade 3 reactions. Grade 4 reactions were rare. There was also quite a bit of fever. Again, you see that the younger subjects had more of these reactions than the older subjects. Headache was really frequent, fatigue, myalgia, arthralgia. There was also quite a bit of gastrointestinal side effects with vomiting and also chills. So quite a strong, not only local, but also systemic reactogenicity. Again, younger subjects more susceptible to those reactions than older subjects. If we look at the list of severe adverse events that were considered related by the investigators, you see a series of events in the vaccinee groups, and you see a series in the placebo group. Looking at those singularly, there isn't really much that comes up. There is something interesting, which is the facial swelling in 2 female subjects that used dermal fillers, which could hint for a reaction to PEG, polyethylene glycol, which is used in such preparations. So then another thing, certainly we are interested in autoimmune reactivity. There is a case of rheumatoid arthritis with an onset of 14 days after the second dose, which, you know, according to what we think about the pathogenesis of rheumatoid arthritis, is probably not really related. Then there is a case of polymyalgia rheumatica, which was seen in the placebo group 15 days after the last dose. If we look at the picture, the global picture of the adverse event, the non-serious ones that were higher in frequency in the vaccine group versus placebo, there were the hypersensitivity related events that were more frequent. In the data set of the submitted data for the registration, there were no anaphylactic or severe hypersensitivity reactions, which were closely related to the vaccine. As you know, there were then some in the post-marketing phase. Lymphadenopathy was clearly more frequent. Also in the Pfizer-BioNTech vaccine, the picture was quite similar. Then the delayed localized reactions with onset after 7 days were a little bit more frequent. And there were 3 cases of Bell's palsy in the vaccinees with respect to 1 in placebo. In the Pfizer-BioNTech, there were 4 cases of Bell's palsy in the vaccinees and 0 in the placebo. So this is possibly a signal, although from the pathogenetic, from the pathogenesis, it's not so easy to understand why this would possibly be related to the vaccine, but that's certainly a side effect, an event that needs attention in the future vigilance on of those vaccines. The serious adverse events, there were a total of 13 deaths. This is the database that had closed in December, so that was a little bit extended. There were, in the vaccine group, there were 7 deaths. And there were 6 deaths and 7 in placebo. There was not really any hint of a relationship to the vaccine. Pregnancies, there were 13 pregnancies observed. There was, in these pregnancies, as we would expect, not really any clear signal or problem, although the outcomes of larger numbers of pregnancies, of course, we do not have data, and this, as with all vaccines and drugs that are new, will need close attention. So the safety can be summarized. This is the FDA summary of their assessment, which coincides with that of the EMA and also with Swissmedic. The totality of the clinical data that was submitted is certainly adequate. The duration of follow-up for a vaccine under the circumstances that we have, with a duration of 2 months, is also to be considered adequate, because most vaccine-related adverse events would expect it to occur within that time frame. We will discuss some unfrequent possible events in a minute. The reactogenicity was clearly more frequent was frequent in absolute terms, but was more frequent in the second dose. The older subjects had less of those side effects. Lymphadenopathy is a problem, is frequent, is certainly related to the immunogenicity of that type of vaccine. Also delayed localized reactions. In the studies that were submitted for registration, anaphylactic reactions were not observed in both types of vaccines or both products. As of the scheduled final analysis, there were the 3 Bell's palsies that will require further investigation and attention. Let me talk about some of the issues that have been raised or can be raised about the safety of this type of vaccine that uses non-replicating mRNA. As you have seen, both products contain polyethylene glycol, so polymers of ethylene oxide. Then you are aware of the properties of these polymers. They are non-toxic, they are viscous, they are in many products, such as laxative and bowel preparations. They are excipients in pills, tablet coatings, lubricants, ultrasound ointment bases, suppositories, wound dressings. So there is a wide use, both internally and also externally, in cosmetic and fragrances. Also the food industry uses it, also the textile, metal and other industries use polyethylene glycol. The hypersensitivity reactions to polyethylene glycol were not really very on the radar of immunologists so far. There is a review on the topic that was published in 2016. I see that the year is lacking. I'm sorry for that, for the reference, from Danish allergologists who did an excellent review about the topic. It is probably underdiagnosed because very often it's not the first thing that people think about when they see maybe an unclear skin rash or another type of hypersensitivity reaction. They look for the more classical causes. The symptoms that are associated in the immediate type PEG hypersensitivity can often be severe, and they are within rapid onset. The exposure in the cases that were so far published as of 2016 was mostly oral, so they had 81% were oral exposures. Of the 37 cases that they looked at, 76% described hypersensitivity reaction that fulfilled the criteria for anaphylaxis. The clinical manifestations were pruritus, tingling, flushing, urticaria, angioedema, hypotension, and bronchospasms. They typically appear within minutes following polyethylene glycol exposure, with many cases describing near instant localized itching or discomfort at the site of the application, and then this is followed by systemic symptoms. In 30% of the cases, the hypersensitivity reactions were severe and mild were reported, both were reported in the same patient. The diagnosis is not still standardized so far, apart from the history and re-exposure skin prick tests with various and relies of re-exposure and skin prick tests with various concentrations of PEG. There was some indication that intermediate weight polyethylene glycol would be more frequently implicated in these kinds of reactions. Here is a plot of the frequency. This may be the case. It may also be related that the intermediate molecular weight polyethylene glycols are used more frequently. These are the guidelines that have been produced to handle this problem in the RNA vaccines that we are using now. These guidelines have been produced by the Swiss Society of Allergology and Immunology, and they are quite useful because a lot of people obviously report some kind of intolerance or some kind of allergy, and the vaccines are now given with a observation period of 15 to 30 minutes to take care of this problem of these anaphylactic reactions. So the red flag comes up if there is a person who has a known or probable allergy to polyethylene glycol, macrogol, and related molecules, or who has had a anaphylaxis after a first dose. These patients should have a contraindication. And then in the yellow zone, you see the intermediate recommendations, which are published and which are also in accord with recommendations for other societies. Let's talk about autoimmunity. There is, of course, if you have a strong immunological stimulus, as we have seen, is quite obvious in man. There is obviously a concern about the triggering of autoimmunity. I would like to show you this paper, which isn't really totally the same of what we are using in these two anti-COVID-19 vaccine. This is this is data from studies done by the Novartis collaborators with self-amplifying RNAs in a mouse model. This RNA was also produced with lipid nanoparticles. They looked at the immune reaction and systemic reactogenicity in mice after injection of nanoparticles with self-amplifying RNA. And they found that looking at gene expression profiling, that in the injection site tissues, there was a robust induction of type 1 interferon and interferon gamma stimulated responses at the site of injection. That concurred with the preliminary reduced self-amplificating RNA expression. I show you this data, which kind of reflects similar but unpublished data about the non-self-replicating mRNA vaccines, which induce similar types of responses. This case is, or this paper that I show you, is a little bit different in that the strong type 1 interferon response, of course, reduces the self-replicating mRNA expression, which you would expect, because that's what the type 1 interferon response wants to do. It wants to prevent that viral RNA is replicating. But what is interesting here is the wide tissue distribution that is shown here by bioluminescence imaging after the injection of this self-replicating RNA into the hind muscles. And you see, at least in the case of self-replicating mRNA, but to a lesser degree also in non-self-replicating mRNA, that there is quite a distribution of these nanoparticles, or of this mRNA that in this case is expressing a luciferase in also in distant tissues. In the animal data of the mRNA vaccines that were used for COVID-19, you can find traces of mRNA also in organs, again in animal models, in the spleen, in the liver, in the lungs, and even in more distant organs. So what does that mean, that the type 1 interferon alpha beta response? This is a typical response of the innate immune system to the challenge with RNA that is guided by TLR7 and 8, which are in the cell, not on the surface, because they have to react to the invading RNAs, which then leads to the activation of the interferon cascade, of the type 1 immune cascade. This type of reactogenicity, or this type of reaction, is linked to autoimmunity. I've taken this from a paper of the big experts of autoimmunity. You see here also Bruce Beutler, who has discovered the TLR4, the LPS receptor on cells. And that's the presumed cascade, which can lead from the stimulation of type 1 interferons to autoimmunity, which goes through the interferon alpha beta pathway then to the activation of interferon gamma, CD4, and silent B cells that become activated and start to produce autoantibodies, and the T cell pathways, which will also lead to tissue damage in different organs. Since the nanoparticles can possibly enter also organs that we are not really, we don't really want them to go into. You could imagine that this kind of cascade can be also stimulated at a distance from the skin where the injection occurs, or the muscle, or the local lymph node. There are several diseases for which we have evidence that they are related to interferon alpha beta. This table shows a summary of that clinical, or this experimental and some clinical data with respect to systemic lupus, insulin-dependent diabetes, multiple sclerosis, rheumatoid arthritis, myasthenia gravis, which of course is a concern if you think that the muscle starts to express spike protein. There you could imagine that the vicinity also be with the neuromuscular junction could possibly induce some kind of autoreactivity either to muscle or to the neuromuscular junction structures. There's also some evidence for an involvement in autoimmune hemolytic anemia. So, so with respect to autoimmunity, we can summarize that lipid nanoparticles containing mRNA induce strong type 1 interferon response. From the animal data, I've shown you data with self-replicating mRNA, but it's also true for the non-self-replicating mRNA. The delivery of mRNA and thus viral antigen expression may not be limited to muscle and lymphatic tissue based on preclinical animal experiments. So there is a potential to trigger de novo autoimmune diseases or hence pre-existing autoimmune phenomena. So far, there are no signals in the available data sets. You would expect to see something within 2 months, but of course, the preclinical phase of autoimmune diseases can also be many years. So there is certainly an uncertainty in this respect, which will certainly be a point of very close attention in post-marketing surveillance of those vaccines. So the monitoring of autoimmunity is part of these commitments. Let's switch another topic, which is still an immunological topic, which is antibody-dependent enhancement. I took this slide from a very nice review that Francesco Negro from Geneva did, published in the Swiss Medical Weekly a few months back. So this here is a slide depicting dengue virus on the upper left, where you have immunoglobulins from a previous infection that may not be super good, maybe not totally neutralizing the virus, and because they are only partly cross-recognize the new virus that is entering. And we know that these suboptimal antibodies can enhance the pathogenesis of this new second infection and cause a often fatal hemorrhagic fever response with macrophage activation and a cytokine storm. And also these antibodies may enhance the viral replication. This phenomenon has been actually the cause of a tragic vaccine failure. This is a picture of parents that bring pictures of immunized kids that were part of the dengue vaxia problem that appeared in a few years back. This problem is still treated by the legal authorities in the Philippines. The story is the following. The dengue vaxia was developed as a attenuated yellow fever virus vaccine that expressed the genes of each of the 4 types of dengue virus. The studies that were done were quite big studies with about 10,000 kids participating, and based on the good outcome of this study, the Philippine FDA approved the vaccine for use in the Philippines in December 2015. And this was promoted by Sanofi Pasteur, who was the patent holder for the vaccine. In April 2016, the Philippine government launched a 67 million public school-based immunization program for the vaccine. There were some experts that said that vaccine could induce antibody-dependent enhancement if the kids didn't have previous exposure to dengue due to the production of suboptimal antibody responses in some of the kids against some of the types of dengue virus. The vaccine panel of the WHO then concluded that the trial could go, or the program could go, and was safe. And the concerns that were risen turned out to be valid in November 2017, after there was a whole series of cases of exacerbated dengue virus infection after the vaccine. And the trial was halted. There was a lot of media and political reactions to the vaccine, and it led also to an alteration in the public opinion about the safety of the vaccine, which certainly impacts now and in the future the use of the vaccines in the Philippines and beyond. The WHO still recommends the vaccine only after there is a test that shows that the kids have been exposed already to dengue. There is dengue virus, of course, is a flavivirus. You cannot just jump from one virus to another, but there is some precedent in another coronavirus, which is feline infectious peritonitis virus, which causes a often fatal infection in cats, in kittens. And there is some data. I show you here 2 papers that relate to that show that this vaccine that is based on that is using a recombinant vaccinia virus expressing feline infectious peritonitis virus sequences, that such a vaccine given to kittens increases or enhances their pathogenesis or their disease after inoculation with the live virus. This has been shown in this paper in the Journal of Virology in '89. There is another paper that showed that if you give convalescent antibodies to kittens and then give them the virus, that they also die more frequently. So there is this is also a classical example of antibody-dependent enhancement in a coronavirus. So again, in the study protocol, this issue was addressed. There were not in neither of the two vaccines, there were the observation of more severe cases. But of course, we have to consider that the COVID-19 SARS-CoV-2 virus is going to stay with us probably in the next years. It's possible that due to mutations, we will need to have future shots, maybe with adenovirus expressing adenoviral vector expressing SARS-CoV-2 spike protein, or we may have to use another mRNA vaccine that contains the modified sequences that we see in the future. And so we could end up with people who have different kinds of exposure histories to different types of vaccine and natural infections, where you could imagine that anti-dependent enhancement phenomena could occur. So I think the antibody-dependent enhancement is going to be something that needs to be looked at in the future. It's not easy to look at it, of course, because we know that the spectrum of diseases is quite occurring in a wide range, from nothing to very severe fatal cases. And since we will not have any placebo groups in the future, we really need good vaccine vigilance to potentially detect such problems. Let's switch gears. Vaccine escape mutants may not be considered really a safety issue, but I will treat it here briefly, also because lack of efficacy of a vaccine tips the balance between safety and efficacy clearly towards the giving more importance to safety issues. So this is from a paper from Emma Hodcroft from Bern that she did with her colleague, and that has been in JAMA. You have probably seen it. Very nice paper that explains the relevance of vaccine or escape mutants, or the new mutants that we have seen coming up, first from England, then from South Africa, now from Brazil and Japan. So this is a slide depicting the genealogical tree, the phylogenetic tree of the vaccine, and it on the y-axis you see the number of substitutions of those two new variants. The orange one below, the B117, has acquired 25 plus substitutions in just one go. Although we haven't seen any intermediates, it doesn't mean that they don't exist. Anyway, this virus has acquired a real high amount of substitutions. The pathogenesis, why this occurs, is up to speculations. A good explanation would be that it has arisen in a person that was exposed to remdesivir, that was immune depressed, and that possibly has also received convalescent plasma. This would be the in vitro condition that would increase the likelihood to see such mutations that have occurred randomly, but also in the antibody binding site. Remdesivir being an antiviral with suboptimal activity against SARS-CoV-2 is clearly mutagenic, and also the antibody exposure with a convalescent serum would explain such a thing. But of course, this is hypothetical. Here you see the emergence of the different lineages over time, and you see this is the isolate from the greater London region, and you see the coming up of this mutant virus that happened first in the London region, southeast of England, and is now clearly also making its way to us with always more and more cases that are of this type. For now, it seems from the data of both vaccines, I show you here the data with the BioNTech vaccine, that there is cross protection, at least against the B117 virus spike protein in vaccinees that have received the Pfizer-BioNTech vaccine. You see the neutralizing titers to the reference virus and to the B117 virus. They are quite similar. And we look for more data. This is also valid for the Moderna vaccine. We look for more data on the South African and the Brazilian virus. So let's talk about another phenomenon, a potential phenomenon that could be of concern, which is the integration into the host cell DNA. The topic was raised by a very well-known group, the group of Rudolf Jänisch. Rudolf Jänisch was a pioneer in molecular biology and applications. He was the father of knockout, knock-in mice. He has done many important work, and his group published this this preprint, which hasn't yet been reviewed, where he investigated the possibility that SARS-CoV-2 RNAs can be reverse transcribed and integrated in the human genome. And he found that there were chimeric transcripts that contained viral fused to cellular sequences in SARS-infected culture cells and primary cells of patients, also in the bronchial alveolar lavage cells. So this could mean that also mRNA derived from a vaccine could potentially end up in our DNA. The link to explain that would be the line 1 expression. Line 1 are transposons that are part of our DNA, that actually make up quite a big part of our DNA. I think about 17% of our DNA are these transposons. Some of these transposons have reverse transcriptase activity. And so you could imagine that RNA that is delivered to cells that ends up in the nucleus could be retrotranscribed and end up in our DNA. This is a little bit a long shot. David Baltimore, though there is not much of a review to this paper yet, there is, however, David Baltimore who took position in a Science article saying that the finding was impressive and unexpected, but he notes that they only show that fragments of SARS-CoV-2 genomes integrate because it is all pieces of the coronavirus genome. It can't lead to infectious RNA or DNA, and therefore it's probably biologically a dead end. according to Baltimore. It is also not clear if in people the cells that harbor the reverse transcripts stay around for a long time or they die. The work raises a lot of interesting questions. So this is also an issue that is at this point not clear. So let me go to the conclusions. I would say the safety profile of the two COVID-19 lipid nanoparticle mRNA vaccines is comparable, both displaying a high local and systemic reactogenicity. The large phase 3 trials have not revealed any serious safety signals up to 2 months after the second dose. The first safety signal in the post-marketing phase has been anaphylaxis, which is rare and probably related to previous sensitization to PEG. Exposure of large numbers of persons around the globe will most certainly raise further safety issues, which need to be carefully addressed, taking background incidence rates of diseases into account. So the example of Bell's palsy, where the background incidence rate is actually not so far from what has been observed. The polarization of the public opinion about vaccines will be impacting negatively on the scientific and public health discussion of safety-related issues. So you have already heard about the Impftoten in the press. These things will certainly be amplified also through the media. Topics of concern requiring careful design post-marketing studies include autoimmunity, antibody-dependent enhancement, viral escape, duration of protection, host genetic modifications, and its consequences. So with this, I would end. This is a view of Lugano with the San Salvatore. And I thank you for your attention. If you want to contact me, this is my email. Have a look at what we're doing at Hepatocentro, clicking on this link. Thank you very much.